Welcome to the conversation tonight, and welcome to the University of Charleston. It's a pleasure to host you. We're going to talk about the apparently simple question of who should decide, should the patient decide, his or her own health care treatment. I want to thank some university friends who have sponsored this evening's program, the Mayer Foundation. The Mayer Foundation has, as part of its programmatic emphasis, to help young adults appreciate the role of ethics in decision-making and in understanding issues. And the Herschel and Elizabeth Sims Fund that is hosted by the Greater Kanawha Valley Foundation. Herschel and Elizabeth were very committed to helping people in this country understand our national motto, In God We Trust. And here tonight representing the foundation and the fund are Brad Rowe, who's the president of the foundation, and Elliot Mayer, and Herc Brad and Angela Sims. We thank them for sponsoring this evening's program. We appreciate it. We'll do a little bit of an introduction of the program, recognizing that next week we begin a rather ambitious five-part series on energy and the future of energy. And I hope you pick up one of those cards that has the dates for those programs. You're encouraged to write out questions and pass them to the aisle, and near the end of the conversation we will ask as many of those questions as we can. Two accomplished experts agreed to come to Charleston to think and talk about tonight's topic. They are the Honorable Tommy Thompson, who was elected governor of West Virginia. I wish. We'll take it.
I love your state, but...
Yeah, not that much, right? Sorry. Governor of Wisconsin for 4 terms, beginning in 1986. In 2001, President George W. Bush appointed him as the U.S. Secretary of Health and Human Services. Secretary Thompson successfully pushed for the adoption of the Medicare Modernization Act that extended Medicare coverage to prescription drugs. He was a candidate for the 2008 presidential election, and last month announced his campaign for the open U.S. Senate seat in Wisconsin. The Honorable Tony Coelho is a former United States Congressman from California who rose to serve as Majority Whip in the House. He was the primary author and sponsor of the Americans with Disabilities Act. In March of 2009, he was named chairperson for the Partnership to Improve Patient Care, which works to amplify the voice of its diverse members, including people with disabilities, racial and ethnic communities, and the elderly. He also serves as board chair of the American Association of People with Disabilities and is currently the president and CEO of the Epilepsy Foundation. I want this to be an ethical conversation tonight, so as background, I share with you my view that ethics is the science of the best possible human behavior. It is the study of what is the best decision, the best action for us to take. So the question in front of us really is it best for the patient to decide his or her treatment? I hope that to raise the ethical questions tonight to the social realm and the value conflicts between the right of the patient to decide, the weighing of costs and benefits, and the providing of equal access to care. Ethics is the consideration of value conflicts. We all have individually and as groups shared values. And when those values, one set of those values comes into conflict with another, that's when the hard ethical issues emerge. Politics is the enaction and the protection of values. In the middle of campaigns, we forget that it's that simple. Every legislative and executive act is the enaction, the pursuit of values. So it is appropriate to have two distinguished and accomplished political figures here. People who have toiled in the healthcare field and have championed better healthcare for all of the American people. To have them here to talk about our subject. They are extraordinarily busy people. We are very grateful that they have squeezed us into their schedules. So thank you for being here for the conversation.
Thank you.
Let me begin and ask, at first glance, would you assume that most people would readily say that, of course, the patient should decide his or her treatment? Do you think we initially think of that as so simple that it's a question we shouldn't ask?
Well, I, for one, as an individual who has epilepsy and have been involved with treatment of epilepsy for 50-some years and been an advocate as such, believe that I have a right to be involved in that decision-making, but with the input of my doctor. I think that if you decide that you as a patient have the total right without the proper input and influence of your doctor, I think you make huge mistakes. But with the input of your doctor, you should have the right to make decisions. I won't go into a lot of details now. Hopefully we'll get into the next hour and a half, but I do not feel that the government should be involved in that decision-making process.
I just have gone through sort of a study of this question. My brother just passed away with metastatic pancreatic cancer. The doctors gave him 4 months to live. He was fortunate to live 14 months. And I say that because when the good dean, Dr. Welch, asked me to come down here and speak, I sort of ruminated that thought process watching my brother, his valiant fight. And when the doctors came in and said, first that they could operate and he had a chance, and then a week later saying that they could not operate, that he didn't, that he only had 4 months to live, the whole process of how do you end your life and what treatments do you take? And my brother was a very strong man, and he said, I just don't want any extraordinary care. I'm willing to fight, and I'll take what you have. And the doctors had a whole regimen laid out for him as to what sort of chemotherapy he could take, what radiation, or what not to take. And he left it up to my brother, which to me, as the congressman said, is the right way to go. I was in all of those meetings, and it was amazing to me how the doctors in this incident, and it's not, I've been in other cases where it's not been so clear cut, that the doctors laid out and were very, very straightforward, that even with the chemotherapy, you're not going to beat this. It's impossible to win. So we went through the process and listening to the doctors lay out the regimen and allowing the patient to choose. And he wanted to make sure, my brother wanted to make sure that when it got bad, he didn't want to continue on. He wanted to have the quality of life if it was possible. And it was a collaboration between himself, his family, and the doctors making the right decisions. But to me, when you look at healthcare, you really have got to have the doctors play an integral part But it's got to, as Tony has said, it's got to be left up to the patient. If that patient is competent to make the decision with the family as to what is the best solution and the best way to go. So I would have to say, without a doubt, the patient is the integral part with the doctors, modern medicine, and the family being there as support and also as the information givers.
Let me bring up another point, though, because, and this will be a little controversial with some of you in the room, I'm sure. As someone with epilepsy, one of the problems I had, and I'll be direct and personal because I think that's the best way we all learn. One of the problems I had was that my parents refused to accept my epilepsy, the doctor's determination of it. And so that one of the problems that we as patients always have is that sometimes our loved ones interfere with diagnosis, interfere with the care that needs to be provided. So when we say decision-making by the patient, and with the concurrence of the doctor, then you always have the complication of others being involved. My parents tried to keep the diagnosis of epilepsy away from me for a long time, and did. They thought I was possessed by the devil. Now, I always say, when I'm giving my speeches on epilepsy to different groups, I always say, Tommy, that my Republican friends know that I'm possessed by the devil, but to have your family think that, it's a little different. But they always used to tell me that it was a lack of calcium or whatever it was, but they would not tell me it was epilepsy. So I ended up going to witch doctors, and I finally refused to go. And ultimately, when I decided to enter the seminary, the doctor who did my physical to go into the Catholic seminary said I couldn't enter because if you had epilepsy or possessed by the devil, you couldn't become a Catholic priest. And so I was eliminated, and I became suicidal. Now, if I had been told early on, I wouldn't have gone through that emotional roller coaster, and I would not have suffered what I suffered and developed the scar tissue and so forth. So the relationship sometimes with loved ones becomes a real problem in the decision making of what a patient can and cannot do. Now, I'm a very devout Catholic, and my relationship with my family worked out, so don't take all these things to be so negative. But it did cause me some serious problems. And so I am very strong about the patient having full information, being able to make decisions with the help of a doctor, and trying to control the influence of others upon that decision making.
I understand, Tony, now why you gave the Republicans so much heck. You're a frustrated priest,
yes,
and you were
right.
preaching, and you wanted to preach. I wanted to add something too. I was Secretary of Health and Human Service. People don't realize what a fantastic department that really is, and how big it is, and how much it encompasses. But one of the programs we have is Medicare. And one of the problems, Tony alluded to it, I'd just like to get it out on the table because I think it's going to lead to some good discussion. And that is that Medicare is going broke. And nobody really wants to say that. We're afraid to talk about it. And 28% of the cost of Medicare is in the last 6 months of a person's life. And the problem is that mother or father or grandpa or grandma probably doesn't want that operation, probably doesn't want to go through any extraordinary care, but son or daughter or niece or nephew has not been home in a long time, to see grandpa and grandma, and they feel, they haven't done their family responsibility. So everything goes. So if grandma and grandpa is, and I've seen so many cases of this, where they'd just as soon not have the operation, just as soon not have the extra care necessary to keep them alive on a tube or artificial eating or whatever the case may be. But it's a lot of people just feel sad that they didn't do more when grandpa or grandma was alive. And I see some of you are nodding your head in agreement with what I'm saying. And as a result of that, they force it upon them. So it's very important for individuals to take control of their health care and make sure that they enter into some sort of negotiations with their doctor and put it in writing, or with their lawyer and put it down. Not that anybody wants any care denied them. It's just that sometimes care is forced upon people that they don't want, and it becomes extremely expensive, and it doesn't accomplish anything. I just wanted to, Tony, you alluded to that, and I wanted to get that out.
Well, you did mention, talking about possibility that particularly near the end of life, that the patient loses the capacity to make decisions. So that would probably be one asterisk on the question of when should patients determine their own treatment. They may lose that capacity. Now, we know everybody should be doing living wills and power of attorneys, and we certainly hope that you do. But absent that, who picks up the reins and makes those decisions? The family member who may have an agenda of his or her own, and is that then the best we can do?
Well, I think that if the patient legitimately, and I think that becomes a big issue, if the patient legitimately loses the ability to make decisions, I sometimes worry about that, but legitimately loses, then the spouse obviously has the legal right to take over, and then after that, the children have the right to take over. And I think that's all fair and right, and I think that's the way it should be done with the doctor. I don't have any trouble with that.
You think we're sometimes quick to make the decision that the patient has lost capacity?
I totally believe that. I think that too often people want to assume responsibility for a patient because the patient is too old, they disagree, or whatever. And I think patients have a capacity to make decisions long into life, and we have a tendency to want to make those decisions for them. I'm a very strong advocate for patients' rights. We have a right to make those decisions and to make mistakes when we're young and to make them when we're old. And as someone who's approaching 70, I have a right to make mistakes now as I did when I was 17. And I don't want people to deny that.
Okay.
I couldn't agree more with him. The patient rights is supreme and has to be. But there is always, in America, a reluctance to talk about death. And I really sincerely believe our medical schools do not teach enough about end of life. And I think you said it, you should take the power of attorneys, the living wills. That's patient-centric. That's number one. The patient's got to put down in writing what he or she really wants. And I hope all of you do that. But then doctors have got to play somewhat of a role in understanding end of life, because I think the most glaring example of that was the Schabel case, where it tied up Congress for 3 weeks, Tony,
Yeah.
because they couldn't come to grips with the end of life. And that should never have gotten to Congress. It should have been handled by the family back in Florida. But families have got to, and if it's not the person, the spouse, the children, they've got to make sure that dad, mother, or grandpa and grandma get to see their lawyer and put it in writing before they become so infirm or unable to make the right decisions.
The Chiavo case, if I recall it correctly, was a woman in Florida who was determined to be in a vegetative state, and her husband wanted to withdraw treatment and remove her from the equipment. And the government, the state, and other officials intervened to say that he could not do that, and then it became a legislative decision of what law are we going to pass or how we're going to decide.
It was different than that. Her husband decided that take her off life support. Right. Her mother and father decided no. So it was family dispute.
Family fight.
Right.
And ultimately the government decided, the courts decided the husband had the rights.
Yeah.
I want to do something that may be uncomfortable, but I happen to think that all of us should always discuss this type of thing within families. And I don't think we do that. And I think that you should. And I'm going to do something that's probably going to make some of you a little uncomfortable. With a show of hands, how many of you ever discussed end of life and try to work it out among your families? Well, that's
amazing.
Impressive. That is impressive.
I'm shocked.
I am shocked. That's impressive.
You're in West Virginia, Governor. It's a wonderful place.
I'm not going to touch that one, I'll tell you.
I'm impressed. That is very, very impressive.
Let me move to one of the issues of contention, and that is experts get together and make statements now about what is best practice. We do all kinds of research, try to understand which procedures are most valuable. What does the best practice standard say to the degree of flexibility or freedom that the patient should have to determine treatment? Should the patient be able to say, I want to do this even though it's not best practice, even though there's evidence to suggest that this treatment won't be beneficial?
First off, the patient has that right and should have that right. But science is improving so dramatically because it's amazing. And in my capacity as secretary, some of the most expensive drugs that are given to patients for high blood pressure, for blood thinners, or so on and so forth, are only effective for maybe 30 to 35% to 40% of the patients. And doctors just willy-nilly hand them out. Patient thinks, it's good for them, and it really doesn't do that patient, some of those patients, any good whatsoever. And it costs the government a lot of money, and it doesn't do the patient any good. And so there's a tremendous amount of research going around personalized health care. We haven't broken through because we're all different. We all respond differently. We all have likes and dislikes of different types of food. Medicines affect us differently. Operations affect us differently. And we really haven't broken through to personalized medicine to the extent necessary that this medicine that this doctor is going to give to you is of your gene type that can actually work on you and work for the betterment of your health. And so we in the department really put a lot of emphasis on personalized medicine, and the National Institutes of Health are doing a lot of work on it, but we're still a long ways away from that. But it's coming, and all I can tell you is that patients have got to determine for themselves what is the best medicines, but it's also got to be in consultation with the doctors.
Yeah, I agree. Personalized medicine is coming because every body is different. Every one of you in this room, your body is different, and consequently, that's why you need a doctor to help you because your body is different. And what we see on TV about this fancy new drug and it's promoted and so forth, And you can talk to any doctor and they'll tell you that the visits they get and the phone calls they get, they'll say, I want to try that drug that I saw on TV because it's a magic drug. It solves X problem. You need to have a doctor explain that because of X drugs that you already are taking, it doesn't work with those drugs, or whatever. There are complications because of your body and your circumstances. It doesn't work. That's why the patient has a lot of say-so, but if you don't get the doctor to help you go through these choices, or if you just depend on the internet, you are in for some negative downfalls. As one who is very active in the epilepsy movement, I have friends who have epilepsy who decide that they're going to go off drugs because they all of a sudden become experts. And they've decided that they're going to do X, Y, and Z, and then they have all kinds of complications and they don't understand why. I particularly have young folks, and I try to mentor and help young teenagers, and they always want to experiment. I remember doing that myself, deciding that I didn't want to take drugs and that I wanted to be able to be seizure-free. I still have seizures. I'm 70 and I still have seizures. But at age 20, I wanted to be seizure-free. And so I go without drugs and I have a seizure and I wonder why. But you've got to work with your doctor to find out what your body can and cannot do. But we're always experimenting, and I understand that. But your body is different, and you've got to work with that doctor to work out what can and cannot work with you.
I don't know if you know this or not, but females and males are different. And it really wasn't until 1988 that medicines that they separated females and really tried medicine on how different medicines would react to females. My wife is very much involved in women's health, and so she keeps telling me, how she was persecuted and discriminated against all these years because she was a woman, and rightly so. And just recently, we've now started dosing children differently, looking at children, and studies saying, children are different. And what is the proper dosage for children? But up until about the middle 80s, most medicines were for adult males. And most of the testing was done. Most of the pharmaceutical companies and biotechs were doing the testing on adult males. And as a result of that, there's been a tremendous change for the better. But it's only been recently that we've really done the same thing for children. And that's, I think Congress passed a new formulation of that for National Institutes of Health to study that. But that's all coming. But it's all part of this, what I was started out with, personalized medicine, that we got to get to. Because we're females, males, different races.
The trials are actually mostly done on white adult males.
Oh.
And that now has been changed in the last couple of decades, and aggressively moving towards what real populations are in the United States. And in order to have programs, in order to develop drugs, in order to develop programs, you got to really represent what our population is made up of. And you can't have programs if you don't do that. So we are, you may not believe that there's a role for the federal government, but there are ways that the federal government can be helpful. There should be these trials that include women, and that should include people from different cultures and so forth, so that when you're recommending something for in regards to high blood pressure or whatever, that we meet the actual subcultures and different populations so that those particular drugs can be very beneficial to all the different subcultures that we have in this great country.
Pick up on one of your comments.
Can I just,
Yeah.
a little bit aside to that, it's amazing, you talked about standards. You can go any place in the world and just about and go into a check machine and get some cash in that particular country. All over the world. You can get insurance. But if you had a stroke here tonight, passed out, and we took you away and down to the closest hospital, and if your spouse or boyfriend or girlfriend was not with you, how long would it take that doctor to be able to determine, what is wrong with you? And they don't want to do you any harm, and medicines that you may have. And we're getting closer to an electronic medical record, but the whole world is on insurance and cash and transmittal of money, but medicines and healthcare, you can't go from Charleston to Washington, D.C. and be able to have your records instantaneously like we should be able to get. And so standards are improving, and rightly so, and we have to have quality assurance improved too, but we're a long ways away, and this is just an example of somebody having a stroke here tonight. It may take you hours before, and you could be dead to get the proper treatment just because of your treatment. So we got to. Government can do a lot of good, as Tony said, but we have a long ways to go.
You were talking about the efficacy of drugs. There's a specific drug for the treatment of breast cancer that the Food and Drug Administration has determined not to be effective. And yet the federal government, through Medicare and Medicaid, will pay out $88,000 a year for patients to use that drug. Does that make sense? How do we balance the desire of a physician or a patient to have a drug that another entity says isn't effective with our being concerned about cost control?
All I can tell you is that coming from a family where my mother-in-law died of breast cancer, my wife had breast cancer, and my young daughter just is getting over breast cancer. Women patients with breast cancer, I think, are the most knowledgeable people about what they want or need. And trying to step between them and saying they can't have a medicine is pretty much tantamount to all-out war. So I would say even though some medicines don't work, unless you got conclusive proof to that, just like there's some people in government do not believe that women under the age of 40 should have mammograms, and there's a lot of just on cost. And when I was secretary, they came out with that thing, and my wife just almost went through the telephone from Madison to D.C. telling me that was crazy, and I came out against it too. So breast cancer is a thing unto itself, and it's a thing that women really understand when they get it and study the medicine. So I'm for one, I'm not going to get between a woman that has breast cancer, and if she wants that medicine, I'm going to see if there's any chance she can get it.
Only thing I'd say on that is that, as a patient advocate, that I think that the issue was the testing of mammograms and the cost of that, and the government study said that for the average and so forth, that it didn't make sense for women of such age to be tested. However, you had evidence that there are a lot of women that under that age were found that the test did work, and found women that were saved as a result of the test. for the government to come out and say that, well, that was a small number, and those that were found that it helped, that is not worth it. Well, I really have trouble with the government taking that attitude. I mean, and thank God that people all over the country rose up in arms, and those government bureaucrats basically had to withdraw their negativity, and that was pulled back. And I also think that when these same type of folks decide that a particular drug is not effective, ultimately, if they come out with those studies and doctors will say that it doesn't work, and patients end up realizing with evidence, not just some bureaucrat saying it, that the evidence that it doesn't work, the patients are going to question it, doctors are going to question it, and ultimately that drug is not going to be used. Mm-hmm. But just because some bureaucrat says that it doesn't work, people are not going to buy it. And so I don't have any trouble with research. I'm a big advocate on research. I'm a big advocate of the information coming out. And I want it on the table. I want it in a way that we can understand it. We have a lot of people in these ivory towers who do this research, and they put out this research that doctors can't understand and that patients can't understand. And we spend a lot of money getting this research that nobody understands. So I'm a big advocate, and I've been pushing it hard in this organization that I'm involved with, is let's stop research that nobody understands. It costs us millions and millions. If they want to do the research, great, but let's put it in a way that our doctors understand, patients understand, and that we can get it out all over the country. And then we make a determination. As a patient, I want good information, and I want information I can depend on. I don't know of any patient that will ignore information that educates me. So if a bureaucrat who tells me that there is a drug out there that doesn't help me with breast cancer, and I'm going to ignore that, poppycock. I don't buy that at all. And so if you tell women that this drug doesn't work on breast cancer, it's not going to be used. But don't, as a bureaucrat, tell me that we're just wasting money. I don't buy that at all. I just don't buy it.
One of the two things that I wanted to add to that, I know you want to ask another question, but this one it's really near and dear to my heart.
It's a conversation.
Near and dear to my heart because, Tony, you're absolutely right. I applaud you for positions you've taken. But the National Institutes of Health, about 75 to 80% of their money goes to researchers around the world and mainly in the United States. The problem is that the research goes out and they may be stumbling onto something, but these scientists just hate to share. They just hate to share the information, and so much information dealing with good health care is wasted. We've done a lot of research, and some of it is great. We have some blockbuster medicines that come out, but a lot of research is obfuscated, and people don't want to help another university or another scientist, and so they do so much research and then they just shelf it. Where if that research could be shared, and there's been more of it, but there's still a long ways to go. That's point number one. The second point is, and I'd just like to ask a question, with the computer now with web pages, I mean, you go to your doctor, there's more and more Americans are going back home and looking up and seeing what disease they have and seeing whether the doctor knows what the heck they're talking about and the medicines they have. Americans are becoming much more experts on the disease they have and the medicines they receive. How many of you in this room, since Tony broke the ice and raised the question, how many of you, when you go to see your doctor and they tell you something, you go back home and look up on the web page and see how correct they are? That's to me, that is fantastic, because you are individual patients that are really able to ask educated questions in with the doctor, and you help the doctor, and you're able to come up, back to our first question, you're able to come up with a better decision as to what medicines you take. So when you ask that question about breast cancer, I'll bet you every woman that has breast cancer goes on the computer and knows more about it than anybody else in the family, and knows almost as much as a doctor, and knows just about the medicines that they take. So I don't buy, women. I buy what Tony says. You want the research, you want the information, and you get that information, but you're not going to take, I don't know of any woman that's going to take any kind of medicine for breast cancer that is not going to help them.
You might want to explain what's a patient advocate, since you are one.
We raise hell.
Okay, you did that as a politician.
We raise heck because it means everything to us. And we want the truth, and we're unwilling to be talked down to, talked at. We want the truth. And so we're willing to take on anybody and everybody in order to get the truth. And that's all we want, nothing else. I'm, as you can probably tell, I'm a Democrat. I'm a so-called liberal Democrat, not always on every issue. But I have no trouble taking on, for instance, Obamacare in areas that I thought were wrong. For instance, I thought that in regards to the health care bill, that there were things that were not good for those of us with disabilities. And I fought the administration and worked with Senate, and I was a House member, but I worked against the House Democrats and worked with the Senate Democrats, and we prevailed on research and got through a program called PCORI, and basically it was to prevent the government to decide what research should be done when they wanted it and so forth. And we set up a group that had stakeholders, including patients, for the first time on a panel with votes to decide what type of research should and could be done. We've never had patients actually have a vote. It was always, we were outside the room. We were on consoles. They could call us when they wanted to, but most of the time they didn't. The department always had the so-called researchers in the ivory towers decide things, but we finally got a group with all the stakeholders, pharma, devices, bio, the ARC and NIH, and patients, actual patients on the board, all with a vote and making decisions for the first time. We actually got in Obamacare pre-existing conditions as part of it. We never had that before. Now it's covered. So basically, there's a lot of things on there, but as patients, we aggressively get involved and try to make a difference. That's what patient advocates do.
I want to move into this other area of contention, and we have a value that says we ought to give care and treatment equally to individuals. We have a value that says that the patient ought to be able to decide his or her treatment. We have a value that says we ought to give the best possible care to every individual. So I want a treatment that I cannot pay for. Should I be able to get it?
Well, if we have certain laws in the books that if you go into the emergency care called EMTALA, they have to take you no matter what it is. The hospital has to, whether you have money or not. Healthcare is, we have all as society have got to come to grips with the fact that society cannot afford the cost of health care without making some changes. And the biggest change is that 78% of the cost of health care goes for chronic illness. And chronic illness can be somewhat changed by people's behavior. We've got a society that's really based upon disease and illness. We wait till people get sick and then we spend lots of money to get you well. And we spend so small of an amount to keep you well in the first place. It's just backwards. So I turned the question around. Instead of saying I want the most expensive medicine, well, you're going to have to also have some responsibility, self-responsibility, individual responsibility, to start eating properly and exercising and so on. And Americans just have not wanted to hear that. But if we're going to afford health care and continue to do the research, we also got to buy into it and have a concomitant responsibility of taking care of ourselves better than we have in the past. 135 million Americans have one or more chronic illnesses, and it's getting worse day by day. And so we have to start, I don't want the government to place responsibilities, we have to do that as individuals, assume the responsibility of taking care of ourselves better and being more concerned about wellness and prevention.
I don't disagree with Tommy on this premise, and that is that if as patients we want to have health care and we want to make sure that when we have a problem that we can get the care that we need, then we have a responsibility to society as well. I think that if you smoke, have you fulfilled your responsibility to society? I don't think you have. And I could go on and on. I think that if you expect society to help you at a time of need, I think you have a responsibility to society as well. As somebody with a disability, I recognize that I have a responsibility, and I exercise and I watch things to make sure that I don't have as many seizures as I might normally. But I have a responsibility. And I think we all do. And so I think there is a give and take. I do believe that, going back to Franklin Roosevelt, that we have an obligation as a society to provide for health care for our citizens. But I do think that we as a society have a responsibility to each other to take care of ourselves. And I think it's a two-way street. And I don't think a lot of us take that seriously. But I do, and I practice it every day, and I think that others got to take that responsibility seriously.
I guess I want to push you on how we go about wrestling with the question, even if I'm not sure there's an absolutely clear answer, and so I don't want to push you into saying you have to totally answer the question. But
Don't give a politician that out.
Yeah, well, let's talk about the issue anyway. I, as a patient, want and need an organ transplant, and I can't pay for it. It's expensive to do the surgery, and there are only so many organs available for transplant. Should I get that transplant because I've been in line long enough and my name comes up on top? Or should that transplant go to somebody who can pay for it, or somebody who has insurance to cover it? How do we as a society wrestle with a hard question like that?
Well, first off, you don't have a right to determine that you need a transplant, and you don't have a right to determine that you need the next transplant.
Well, I thought the patient is supposed to be involved in making determinations about treatment.
Well, but the point is that a doctor determines whether or not you need a transplant, not you.
Okay.
And so, I mean, I'm a patient advocate with a doctor. I mean, I don't think you become a doctor. I think you're a patient, and I think you have to have a doctor as your partner. So I think that if the doctor determines that a transplant is needed under our system, then you go on a donor list. And that has been decided, and we don't have enough donors, and you can't, in effect, force somebody aside because you decide you want to. There's a system on the donors list, and I wish there were more donors, but we can't. I just don't think that a patient has a right to shove other people aside because they decide they want it. I'm a patient advocate, but I'm not a selfish patient advocate. I think there is a system, and you got to participate in the system.
Dean Welch, I became very active in organ procurement and transplants. I was given a dinner one night, and I invited the German ambassador was in Wisconsin. I gave a special dinner for him, invited in some of the German citizens of Wisconsin, and one of the foremost transplant surgeons in the world is at the University of Madison dealing with kidneys and livers, and he didn't show up. And I asked him when he came in, how come you're stiffing me and embarrassing the ambassador because I told him you were coming, you put him at your table. And he was crying. And this guy he says, I just lost a patient. And I said, why? And he said, because he was from Switzerland, he came over and we couldn't find a kidney or liver for him, and he'd been on the list for a long time, and I really liked the guy, and I lost him. And I said, what could I do? And he said, well, you can go out and you can talk a lot about transplants. You're not going to have the example you have because Tony's right. You have a registry. And by the time you get up to that list, hopefully there's somebody out there that's going to give you the organ you need. But right now, today, we got 100,000 Americans that are waiting for an organ, mostly kidneys and livers at the most. And there's 19, a person dies every 19 minutes for lack of a transplant. And can you imagine the angst of that family waiting for a transplant, whether or not you're going to get one before you die? And the chances, probabilities are not very good. And so once you get up to the top of the list, even if you don't have money, and there's somebody that's had an accident and you harvest the organs, you only got a minute amount of time before that organ spoils and is not usable. So you can't be waiting around whether or not you've got money or waiting around for somebody to come and pay the bill. You've got to get that organ harvested from the person that's dying, and you got to give it into that person that's on the list available for it as soon as possible. You don't want to waste it. We waste almost right now about 2 out of every 5 hearts. You got to get a heart into a body within 4 hours after you harvest it. And so you can't be waiting around deciding if you're going to be on the list or not. If you're on that list and you're in the hospital waiting for a heart, you're going to get it because you can't afford to lose that heart. And we got to, as a society, we got to put more people on notice that they've got to donate their organs. I tell people the good Lord doesn't want your organs in heaven, he wants your soul. And I also said if your organs had a chance to vote upon your death, that your eyes would certainly vote to be able to continue seeing in somebody else's body, and your heart would certainly continue to vote to beat in somebody else's body instead of being buried in a casket. And I know your kidneys and livers would vote to continue to drink Wisconsin beer and eat Wisconsin cheese instead of being buried. So I think the transplants, I don't think is a good example because you don't have the choice. If you're on the list and they have a transplant, you're going to get it.
Right.
We have some questions from the audience, and if others of you have questions, pass them to the aisles and we'll pick them up and ask a number of them. This person asks, this is somebody who sent in a question ahead of time over the internet. Why can't the United States follow the most economical healthcare system model with the best outcomes proven throughout the developed world, namely universal healthcare, covering everyone, known as a single payer or Medicare for all? Other advanced nations do it. Why can't we?
You want to go first? Or?
No, go ahead.
Okay. Well, I don't believe in universal health. I don't believe in government control. I believe that individuals should have a determination of their health control system. I don't think we could afford it. I don't think it's the right way to go, and I believe that the system we have is going to have to be changed completely. But I don't believe there's the. I don't think either political party at this point in time, some members in Tony's party would support universal health, but I don't know if the majority of the Democrats would, and I know the Republicans don't. So I don't see how you would ever pass it. I don't support it, and believe that we have to redo Obamacare and put in a different system that's more market-based than what we have.
I think that the writer of that question looks at universal health care without any of the problems of universal health care. There's a lot of problems with universal health care as well. The waiting lines and the predetermined drugs and so forth. Just take my experiences with epilepsy. There's only a certain number of epilepsy drugs that are approved, and for me, for instance, I would not be able to have a drug because I take one that would not be on any approved list, and so I would not have my seizures under basic control, and that's what a government-run program would do. I like the concept of some type of universal system, and I think we can get that, but the type of system this writer is talking about just doesn't work in our country. We would revolt against it. We have a lot of people. This writer, I'm sure, would say that there are a lot of people who go to Canada or go someplace else to get service, but I know a lot of people who come from Canada to our system because they get better service here. We get better quality, and they don't have to wait 6 months to get an appointment, and so forth. So I think what we need to do is to concentrate on how we better improve our system, because I still think our system is the best system on earth.
A couple of questions here about electronic records. I'll give you both of them at the same time. What do you think of the empowered patients movement that continues to push for the increase in patient involvement in their own treatment plans through the use of electronic medical records? And on the other hand, someone says there are many attributes to electronic medical records. However, there are significant dangers, and how do we ensure that privacy is respected and that patients can have confidence in the integrity and accuracy of electronic data?
Well, Tommy mentioned the positive things about medical records, and somebody having a problem here in Charleston that they actually come from Washington, D.C., we could immediately take care of them. That's the positiveness of them. Privacy is a huge issue that obviously we're trying to address and will address. There's no doubt about that. So I am a big advocate of it because I I think we are a nation that is on the move constantly. And so some type of records that are universal, that can be, that you can reach and deal with anywhere in the United States or anywhere in the world is a tremendous asset. And I think that we will move that way, whether we like it or not. And I think it'll be of tremendous benefit. You'll save a lot of lives, and you won't have a lot of negatives. There will end up being some problem, of course, with technology. There always is some problems, but the benefits will be much, much better.
I'm amazed, you know, we've become such a partisan society in America. And I don't think it's worked out for the benefit of the citizens at large. And I'm going through that right now. But there are sometimes even the blind squirrel finds the acorn. And Democrats and Republicans have come together pretty much on electronic medical records, and I applaud both parties. And the same thing, both political parties have come together on wellness and prevention and chronic illnesses. Two giant steps forwards in the healthcare arena that if we could build upon those, we could make a lot of progress. Electronic medical records, you know, you couldn't get along without electronic records dealing with your paying of your bills, your finances. And people say, well, electronic medical records, what about privacy? And I said the same privacy concerns were about your money and your stocks and your bonds, and all that is always electronically transferred. Your checks are deposited in your accounts and so on and so forth. And nothing is more personal to you than your checks and what you receive and so on and so forth. That's going into your thing. And have you ever thought, you know, in a clinic or a hospital, those manila envelopes that are floating around give you a degree of security about, oh, I just peeked a little bit. It was open, so I looked at it. I mean, electronic medical records, from my point of view, are much more secure and much more private than those multitude of manila folders that are put in the clinic office and the doctor's office and the hospital. So I think that we can make a lot of progress here, and we should. Healthcare, as Tony says, we travel so much. If you get ill someplace, you need your records instantaneously so the doctor can treat you and not do harm to you.
I've heard several people comment and raise questions, and we've had some submitted tonight about cost issues, saying that patients can't read a bill. There's no way for a patient really to understand what a procedure costs, and therefore the patient is eliminated from having any role in controlling the cost of health care and going out and searching for less costly alternatives. Is there any solution to this to help patients understand the cost of their own care?
There has to be. I mean, it's just the height of foolishness to get the amount of bills and things that you can't understand. And how many of you that are on Medicare get those EOBs, explanation of benefits? Does anybody understand them? I was secretary. I couldn't understand them, and I'm fairly bright. Couldn't understand those EOBs, explanation of your benefits. We've got to, as a society, demand a degree of accuracy and more reliability, and get rid of the fraud in the system as much as possible. And we'd get rid of a lot more fraud if the bills were simplified and put in language that we could understand and figure out, instead of these multitudes of explanation of benefits that nobody can understand and nobody knows how to read or decipher.
I agree with Tommy totally. I think that there's a stress in regards to going after a drug that I take or device that I have or whatever. But if I look at these records and the cost that it is to take an aspirin or the cost that it is to do whatever, I just really question whether or not I actually took these and how much it costs to give me an aspirin, and so on. And I think that is something that we really need to really look at. And I stress that there's where we could save a lot of money if we paid attention to it. So, I mean, I agree with Tommy totally on this area.
What's the role of insurance companies in all of this? Should does it make sense to say, well, they decide what they want to cover, and if you want to buy that policy, that's fine? Or should we be in the situation of telling insurance companies what they ought to cover? How do we work out what their role ought to be in healthcare?
Make less money. And I'm a big capitalist, and I believe that, I've been out of government, and I believe that our system works, but I always get fascinated with insurance companies that charge you fees, and you pay all these fees, and then when you run into trouble, they get rid of your insurance because you cost them too much. Why did you pay all this insurance for all those years if they aren't supposed to take care of you when you then need them? And then you watch their profit statements, and they've made all these profits. And I'm not anti-insurance company, just that I think there's a system of fairness that should be maintained, and I just don't think we do that, and I think we need to do a better job of maintaining about what they do and don't do. And I'm not a big advocate of government controlling things, as you've been able to tell tonight, but I really have trouble with what the insurance companies do and get away with, arbitrarily deciding they're not going to cover a particular hospital, or arbitrarily decide that they're not going to cover something. I just have difficulty with that, and there are probably some insurance company reps here in the audience. But I have a great deal of concern with that, and I think it's one of the things that's broken in our system.
We have to realize that you cannot have a system like we have without insurance companies. So they're a necessary part of the system. But there has to be more competition and more transparency and more ability to read the policies and understand what you're paying for. And we just, as a society, we gotta demand that and expect that. That when you get a policy, you know what you're getting, and you know what it's gonna provide for, and so that you have some control. I like Tony, believe very much in the control over the healthcare system, and that individuals have got to play a bigger role. But if you don't understand and can't understand what's in that policy, and you're on an unequal footing, and you're going to lose out every day of the week. And that's why what Tony's saying, we have to make some changes. But insurance companies play an important role. We just got to make sure that they adhere to the rules and are transparent, and there's more competition.
I think, in fairness, so that you understand the toughness on this issue, is that if you have a child born into your family that has a disability, the insurance company, in a lot of cases, will take away your insurance. Now, you've paid insurance for X number of years, and you have a child with a disability. Now, with the health bill that was adopted by Congress in the last couple of years, now I wasn't there, so I'm not taking credit for it, but from the disability community point of view, that now is prevented. They can't do that. But that's outrageous, it seems to me, that you've been paying money as a family to have this insurance, and you end up with a child with a disability, and then they drop you. That's the type of thing that's very frustrating to me, and that's why I'm, as a person with a disability advocate, and a patient advocate, you can see why I feel as strongly as I do about this.
Interesting question. If a patient has capacity and has discussed his condition with his physician, why is doctor-assisted suicide not an acceptable value for a terminal patient?
I have no trouble with it, so I'll get that over with. So I think you have rights as a patient. As I said, I'm a devout Catholic, even though I went through my trials and tribulations with my church. I think as an individual, you have rights, and I think working with your doctor, you have rights for your quality of your life. As I make decisions about my health condition, I'm a big advocate on quality of life. I don't want a doctor to drug me up so I don't have any seizures, and then I can't enjoy my life. I want a balance. I don't mind having seizures as long as I can enjoy my life and do things. And so I don't want a doctor to drug me up so I don't have good quality of life. If you get to a situation where your quality of life isn't there, I think you have a right as a patient to make some decisions with your doctor. I think that's a right as a patient.
I'm not there. I think it's going just too far as to allowing it. Tony and I have been getting along very well tonight, but there's got to be a point where there's some difference, and I do not believe that a person has a right to take his or her life.
Okay. And you don't both have to answer questions, but if you both want to respond to a question, that's fine too.
Are you, usually proctors say that because you're running out of time, and you're just saying,
we're still okay.
Trying to be nice to just shut up. Is that what you're trying to do?
I don't say that to governors, sorry. Not even in Wisconsin. Okay. What opinion do you have regarding direct-to-consumer pharmaceutical advertising?
Direct-to-consumer.
So I assume pharmaceutical companies advertising directly to consumers saying, buy my drug and use it for yourself, as opposed to doing that through physicians and healthcare personnel.
I assume by mail or by internet and so forth. Is that what they're saying? They do it today.
For TV, what have you?
They do it today.
Right. Well, is that good?
I don't. I'm bright enough to delete them.
I think I think the problem is we don't get enough information out.
Yeah.
And I'm big on information. That's why we have the web page and the internet and so on and so forth. I don't see anything wrong with giving information. I only wish, instead of spending all that amount of money on selling their own individual drugs, that they would talk about classes of illness and diseases and how people could stay healthy. I would love to see pharmaceutical companies spend a portion of their advertising budgets on how all of us as Americans could do a better job of staying healthy. That's what we have to get to our society, and we have a responsibility to do that. And they spend all their money just selling their pills and medicines, which I don't have any fault with that, because I think education is good. I just wish they would spend an equal amount or a portion of that amount on telling you how you can stay healthy.
I think the only thing, in fairness to them, and I'm not an advocate for pharmaceutical companies, but I just went through a scare on bladder cancer, and I immediately went to the internet, listened to my doctor, then went right to the internet. Spent a lot of time looking at the internet. And I was very impressed with the pharmaceutical companies and what they had on the internet, educating you about what bladder cancer was, what to look for, and all the alternatives and so forth, and talking about different drugs and so forth. But I came away rather educated on bladder cancer, more by the drug companies than I was about the government and so forth. I was very impressed. I printed it all out. I had a stack of stuff this big, and I was reading it, and so forth. But I'm not impressed with what I get in the emails and all that junk that I get from internet, but from pharmaceuticals. But I was very impressed with how educated I became on the internet, because I thought they did a good job there. I was surprised.
If we agree that patients should have a choice in health care, is it conceivable that the physician will ultimately make the choice of quality of life for an elderly person? Should the physician determine that care, or should the patient's advocate?
I think the patient's advocate and the patient's got to play the major role, and the family. I don't think that you can leave that up to the doctor. I think the doctor's got a major role to play, as he did in my brother's case, but I really think it's got to be the patient's advocate and the family.
I guess I agree with that, although I have doctors that have been my doctors for many years, and I think they have a better knowledge about my disorder than my advocates. And I think in those situations, I have told my family that in those situations, I would rather have my doctor make the decision than them. But if it's some doctor that doesn't know me, I'd rather have my advocates do it. But I think there becomes a balance there, and I don't think anything's black and white. I think the patient should educate people. That's why I asked for a raise of hands. How many of you have discussed it? My family knows that what I would like to see if something happens to me today, or if something happens to me 5 years from now, and I'll probably change my mind 3 years from now. But I think it should be an ongoing conversation. I'm not afraid to discuss it.
Is there a way more citizens could be assisted to create a living will? Could we do something like the voters' registration campaigns that we have every election cycle to encourage citizens to write a living will?
I would love it, but I don't know if voter registration is the way to go. I really sincerely believe that all of us have got to do a living will. I got one, and how many do have a living will? That's
less than people talk about end of life. That's interesting.
That's pretty impressive.
It is.
But you gotta. I think society's moving in that direction. Yeah. I really think that people are starting to realize that as they get older, that they want to have some control over their life, and before they become so infirm that they can't make an educated decision, that they're putting it down in writing.
I don't think you'll get a living will until people are willing to talk about end of life.
Yeah, that's great.
I mean, once you are willing to talk about what happens to me if I become disabled, or what happens to me if I die, once you start having that conversation, then you'll do living wills. But you got to get over the first hump. And that's a hard discussion to start because, some couples will think, are you trying to get rid of me? But I mean, that's the first discussion you got to have. The rest of the stuff falls into place, but you got to have that first discussion.
Should patients have some financial accountability for expensive technology when, first, there is a clear evidence of benefit, and second, there is no clear evidence of benefit? Should patients have financial accountability for expensive technology that they want used?
And the best of all worlds, sure. But we're dealing with human beings that are not perfect, and they're not always going to have the wherewithal for that. And each situation is going to be different. Are you covered by insurance? You get covered by Medicare? You covered by Medicaid? And do you have your own individual wealth in order to do that? And then you're not going to deprive somebody that doesn't if that procedure is going to save that person's life. So it's I don't think you can generalize that question and say yes or no. I think you have to look at the situation and the circumstances to make a right decision.
And also, I think in that question, I was born and raised, represented an area in Central California. My hometown is 2,000 people. You're not going to get the absolute best care in that community. When the doctor saw my first seizure, when I woke up from the seizure, he was sitting on me. Now, that's an interesting way to treat a seizure, but he was sitting on me.
Was he heavy?
It was kind of heavy, and I think he maybe kind of controlled the seizure when he sat on me. I was 16. But I think that there are parts of our country you're not going to get the best care. I mean, there's no doubt about it. In here, parts of West Virginia, parts of California, parts of wherever you are, and in other parts of the country, there's better care. So I think that a lot of it depends on where you are and so forth. And if you're from my area where I was born and raised, for you to demand real expensive care and so forth with the best doctor, they're going to laugh at you because it ain't going to happen. And so I think that the best care possible in that area is going to be different than the best care possible here in West Virginia. And I think that is an accepted thing in our society.
But you are both political creatures, so I'll give you the opportunity to say if there's one thing that government could do, one thing we could enact, either to take away something we're doing now or to add something that would improve the quality of health care for individuals in this country, what would be your magic wand to see us do?
Well, I don't think there's any question. My magic wand would be, first off, I think that leading up to my answer, I'd have to say one of the biggest problems we have facing our country is that we have become so partisan, far right and the far left, and nobody wants to talk anymore about issues and about solutions. And I feel really bad about that because that's not how we're going to change the healthcare system. If I had the one thing I would do is I would have people take more of a responsibility for their health care. Because as I previously said, 78% of the total cost of health care goes for chronic illnesses. And most of those chronic illnesses are things we bring on ourselves. And if you want to change health care, we have got to change our society from a disease system, an illness system, to a wellness system, and deal with with exercising, eating properly, and trying smoking cessation and things that are going to make us a healthier society and save money and have a better quality of life. And I just don't see us doing that to the extent that I would like to see.
I happen to agree with Tommy on this. I think that one of the things that I'd like to see, if it were at all possible, is to have us take personal responsibility for our own individual health. Not health care, our own individual health. Mm-hmm. Because if we did, a lot of the health care would be taken care of. But I don't think we do. And as a matter of fact, we make fun of people who take care of themselves. And instead of all trying to take care of what we eat, what we do, trying to improve ourselves and so forth. And I think that if we did more of prevention, if we did more of healthcare, we'd eliminate a lot of the healthcare problems. I know there are people that can't do certain things, but a majority of our people could change their lives if they did that. That's my wish, as you say. That would be the thing that I think could change society. Do I think that'll happen? That's my wish. That's what I would like to see happen. I don't think it'll happen, but I would love it to happen, because I think we all would be much happier people, and we could eliminate lots and lots of unhappiness, lots and lots of costs, and we would set examples. We do a lot throughout the world. We export a lot of good things, a lot of good deeds. As been said here, I was the author of the ADA. The ADA is now the law of the land in over 50 different countries. Just think if we could really get into prevention, and if we could really get into doing something in regards of our own individual health, and we exported that all over the world. What a great world this would be.
Both of you have shared with us your own personal stories. That's special. We appreciate your being willing to share those your own experiences, and to come from Wisconsin via London and from Delaware via D.C. to West Virginia for this conversation. Thank you very much, and look forward to seeing you next week for Energy.